Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out reallifepharmacology.com. We've got the free 31-page PDF on the top 200 drugs. It's a great study guide, great refresher. And also, please support the sponsor, meded101.com/store. We've got tons of resources, books for board exams and various items like that. So again, your support there goes directly to help this podcast. All right, so today I had a request, and I'm going to cover some food supplement interactions. And one of the first ones I'm going to start out with here is grapefruit juice. And if you recall, if you're a close follower of the podcast, I have done a whole episode on grapefruit juice drug interactions. So not going to spend much time on this, supplement, food, whatever you want to call it. But recall that it is a CYP3A4 inhibitor, and there's a lot of drugs that are broken down and metabolized by CYP3A4. So just a quick refresher, numerous statins, amiodarone, colchicine, some of the immunosuppressive agents like tacrolimus, for example, calcium channel blockers. These are all drugs that are broken down significantly by CYP3A4. Naturally, they're going to have their concentrations rise, and we're going to be more likely to have toxicity type situations with those meds. So that is grapefruit juice in a nutshell. Again, if you want more details on that, definitely refer back to a previous podcast episode. All right, next ones, I guess there's three supplements that I've historically heard about in pharmacy school. Particularly, I remember them a few times being mentioned there. Garlic, ginseng, and ginkgo. These have a theoretical risk, potentially, of increasing bleeding. So probably most concerning in patients on antiplatelet medications, anticoagulant medications, and folks like that. Maybe NSAIDs as well. How worried do I get about these? Obviously, if anyone has any bleeding or bruising, that's a good time to reassess and take a look at that and say, hey, is the garlic you're taking really having any benefit for you? Because there is, maybe some potential that it could be causing some harm. So anytime you run into those type of situations where we're clearly seeing potential adverse effects, bleeding, bruising, so on and so forth, that's a situation where you've got to reassess those three agents if a patient is definitely taking them. If, I've got a patient that isn't having any issues, but maybe they're on an anticoagulant and an antiplatelet medication, I definitely discuss that, with the provider and or the patient and say, why are we taking, ginseng or garlic or ginkgo, and really assess, do we feel like it's really been beneficial for the patient? And if it hasn't, then I'm inclined, obviously, to discontinue that. I probably see patients use them to try to, enhance memory or improve memory function. Those are the most purported uses. I'm not incredibly sold on the evidence that they really benefit that much, but that's one of the main reasons I see those used. Another food supplement, or I guess supplement here, milk thistle. Milk thistle is not a strong inhibitor, I guess, but more of a weak inhibitor of CYP2C9. There are some pretty heavy-duty drugs that use CYP2C9 for metabolism. So phenytoin's a great example, older anti-seizure medication. And then warfarin's the other example as well. So if you got a patient taking phenytoin, let's say, for example, and they start taking milk thistle as a supplement, that could certainly increase the concentrations, or at least we have that risk of increasing the concentrations of phenytoin and potentially leading to phenytoin toxicity. Next one I wanted to mention, it's definitely one that can come up on board exams, which, reminder, we've got some great pharmacist board exam study material at meded101.com/store. But St. John's wort is that one. This medication is an enzyme inducer. can cause lots of problems with numerous medications. I can't think of a situation in my practice where I recommended for a patient to start St. John's wort or continue it if they've been on it. There may be a rare case out there where patients feel like it's been incredibly beneficial, and maybe you've got to work through that risk versus benefit with them. But by and large, St. John's wort, tons and tons of drug interactions, and certainly should be avoided in most situations. The next thing I wanted to talk about were, I guess, a couple of food or, beverages, dairy products. So, thinking like milk, cheese, that type of thing. There's a few drugs that can be significantly bound by dairy products. And antibiotics are probably the first thing I look out for because we really don't want to risk treatment failure. And again, this is just oral. So if we give, an IV quinolone antibiotic, for example, that absorption isn't going to be impacted, and it's not going to be an issue with the timing of administration there. So tetracycline derivatives, doxycycline, tetracycline, and so on and so forth. And then quinolone antibiotics, ciprofloxacin, levofloxacin being the two most common there. Co-administration with those oral products in combination with dairy products can lead to basically a blocking of that absorption, lower concentrations than we would like, potentially subtherapeutic, where it's not going to treat our infection, and ultimately lead to antibiotic failure, which is never a good thing. A couple others that I did want to mention with dairy products, bisphosphonates, and really bisphosphonates shouldn't be taken with any food or beverage in general other than water, plain water. Again, binding situation, and levothyroxine is another one I've seen as well. So, dairy products, it's definitely important to pay attention to the timing of that because there's a lot of patients that certainly drink milk and cheese and those type of things that have that calcium that can bind up those agents. And I guess I would add in here calcium supplements as well, and iron and magnesium and those type of things too. All right, let's touch on a common beverage that is frequently used. So we've got alcohol, of course. It is a CNS depressant, and it can certainly have additive effects with other sedative type agents. So probably, worst of the worst, opioids, benzodiazepines, some of the older skeletal muscle relaxants, cyclobenzaprine, for example, sleeping type medications, such as zolpidem, for example. That additive CNS depressant effect can be a significant issue. And obviously, this is a dose-dependent risk, so the more alcohol a patient consumes, likely the higher the risk for sedation and slurred speech and some of the other signs and symptoms of alcohol toxicity there. In addition to the CNS depressant effect of alcohol, recall that, for maybe more chronic users, larger intake, liver toxicity risk does exist as well. And that in combination potentially with other liver toxic agents, particularly amiodarone, I think of isoniazid. These maybe shouldn't be used together if at all possible, or it's a good reason to encourage your patients to try to minimize their alcohol intake. And then, of course, we've got acetaminophen as well. I guess you could put in that bucket too. Particularly more concerning, in patients with liver impairment, and then, maybe those at higher dosages of acetaminophen. With alcohol, I did want to mention that there is potentially some greater risk for hypoglycemia, or particularly in patients, obviously taking insulin or sulfonylureas too. So that's something to keep tabs on, particularly if you've got a patient that's reporting hypoglycemia fairly frequently. Might be a good double take kind of to just, reassess their alcohol intake and make sure that's not complicating anything. And then we've got some vitamins as well that I wanted to mention as we kind of wrap up here on the podcast. So vitamin K, that's one that you're going to be asked on pharmacology exams in school if you're going through that. Warfarin and vitamin K. Vitamin K is an essential component in the creation of clotting factors. So that consistency of intake is really what we're looking for in a patient taking warfarin. So more vitamin K intake, you'll actually get lower activity of warfarin and lower INRs if you're following that. And then with reduced intake potentially, so think of a situation where maybe a patient's sick for a period of time, maybe their vitamin K intake has dropped. And that's going to have the opposite effect where that INR could go higher and higher as that vitamin K intake drops there. Vitamin C, I wanted to mention a little bit. Absorption can be reduced with certain medications. Amphetamine derivatives, probably the one that comes to mind most there. So in an acidic environment, which vitamin C helps produce, that absorption of those amphetamine derivatives are going to be reduced and potentially lead to, obviously, lower concentrations there. The other thing I commonly see in practice with vitamin C is, I guess maybe not commonly, but I see it periodically. It's potentially used in combination with iron supplements to enhance absorption with iron. So that's a thing to pay attention to as well, and something you might see in practice. Vitamin E has been, theoretically proposed to contribute to bleeding risk. I don't think the evidence is crazy great or crazy strong on that, but I don't really see a need particularly usually for patients to supplement vitamin E either. So again, generally a vitamin supplement, particularly in my polypharmacy patients, that I'm generally just asking, can we get rid of it? And then vitamin B3 and niacin. So niacin, has been used for hypertriglyceridemia potentially. Again, not an amazing agent. It causes some flushing and other issues as well. But when used in combination with statins, the risk for rhabdomyolysis is a little bit higher there. And then last but not least, I wanted to allude to a few interactions with supplements, particularly. I alluded to them before with some of the quinolones and tetracyclines and dairy products and things. But calcium, magnesium, iron, zinc, those are considered metal cations, and they tend to strongly bind some of those medications. So the quinolones, tetracyclines, levothyroxine, iron as well is another good example that can impact the concentrations of those medications. And while I'm on iron, finishing up, iron can have its absorption reduced with acid-suppressing type medications. So PPIs, H2 blockers, antacids used to reduce antacid in the stomach. Iron ideally needs an acidic environment. So I alluded to the vitamin C, helping with the iron absorption. So iron can potentially have its absorption reduced if we're taking medications that reduce the amount of acid in the stomach. All right, well, I think that's going to wrap up the podcast for today. Hopefully that gives you a quick overview on some of the commonly used vitamins and supplements that may cause drug interactions in practice. Do me a huge favor, leave a rating, review on iTunes or whatever platform you're listening on. I greatly appreciate that. Share us with friends, colleagues, those who are interested in medications, medication safety, pharmacology. We think this podcast, or I think this podcast has been a great resource to a lot of people, judging by some of the comments and emails I get. So speaking of emails, you can track me down at mededucation101@gmail.com if there's something you're interested in or want to hear me cover on the podcast. I'm certainly open to ideas there. If you're looking for something, I've got over 300 episodes now on various drugs and topics. So please go to reallifepharmacology.com and you can browse all the episodes on the website there. So don't hesitate to go check that out. As always, go check out the books, the resources, courses, everything at medid101.com/store. Lots of good stuff there that have helped people pass board exams like BCPS, ambulatory care, NAPLEX, and many, many others. So go support the sponsor for this podcast. I greatly appreciate that. And of course, if you want to track me down, I mentioned my email, mededucation101@gmail.com. And you can find me at LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. Thank you guys so much for listening. Hope you picked up a few practice pearls today, and I hope you have a great rest of your day.